So today, what Sudhakar had asked to do is to present one case and to discuss it at length, because two of the other speakers we had hoped for were not ready, available for today. So the format is that she will present a case that they recently had, because as you all are aware, even though COVID-19 has occupied us completely for the past 1 year, people could also be dying of other causes. So this one case might generate such a discussion about what is the cause of death here. So Dr. Shailaja, please present the case that you have. Go ahead.
Good morning to all respected sirs and madams, and good evening, and good morning to all US faculty members. And I'm Dr. G. Shailaja of General Medicine Department. My topic today is sudden death in COVID-19. The case of 56 years old male patient Ni D. Apparao, resident of Fort Colony, Visakhapatnam, came with his son on 12 a.m. on 22nd March 2021 with chief complaints of fever, dry cough, cold since 4 days, body pains, and there is one episode of vomiting 1 day back, and there is recent history of travel to Tirupati also present, and no history of shortness of breath, and no history of chest pain, palpitations, and dizziness, and there's no decreased urine output, and no abdominal distension and facial puffiness. And there's no contact also with another COVID positive person. Past history, he is known diabetic since 2 years on regular medication, tablet metformin 500 mg TID dose he is using. And there's no history of hypertension, bronchial asthma, pulmonary tuberculosis, and epilepsy. And on general examination, patient is conscious and coherent, and GCS score was 15. Blood pressure is 140 by 90 mm mercury was noted, and pulse rate is 102 beats per minute, regular, normal volume. Respiratory rate is 19 cycles per minute, and no use of axillary muscles of respiration. And patient is afebride at that time, 98.4 degrees Fahrenheit is recorded. And the saturation of oxygen is 95% with room air. And there's no pallor, icterus, cyanosis, and pedal edema. And on systemic examination, cardiovascular system, first heart sound and second heart sounds were heard, and the jugular venous pressure was not elevated, and no murmurs and auscultation. And respiratory system, bilateral air entry was present, and there were normal vesicular breath sounds, and few crackles were heard at right basal region. And perabdominal examination, soft and non-tender. And on central nervous system examination, higher mental functions were normal. And patient came with rapid antigen test turned positive, and then admitted in ward of CSR block. And diagnosis was COVID-19 pneumonia with diabetes mellitus. Lab investigations sent were hemoglobin 11.8 gram percent, RBS 332 milligram per DL, and renal function test is blood urea 46 milligram per deciliters, serum creatinine is 0.9 milligram per deciliters. Liver function test, total bilirubin 0.6 milligram per DL, direct bilirubin also 0.3 milligram per DL, indirect bilirubin also 0.3 milligram per DL. And SgO2 38 units per liters, SGPT and 27 units per liters. Serum electrolytes were normal, sodium 146 millimoles per liters, and potassium is 4.32 millimoles per liters. D-dimer value is 0.87 milligram per liters. ECG rate is 100 beats per minute, and normal rhythms, normal sign axis, and no evidence of ischemia or infarction. ECG was here, there is tachycardia present, and X-ray shown is bilateral confluent peripheral age-space opacities involving all zones on the right side and left mid-zone. And HRCT done, it showed patchy areas of ground glass attenuation with septal thickening noted involving bilateral lung parenchyma, suggestive of viral pneumonitis. And there is also mild bilateral minimal pleural effusion also noted. And treatment given was antibiotic doxycycline 100 mg and tablet ivermectin 12 mg is given, and pantoprazole 40 milligrams and the supportive B complex or vitamin C also given. And for diabetes, insulin actrapid 6 units TID dose and intermediate insulin 8 units at 10 p.m. Given. And later, on the same day, he had his dinner at 10 p.m. at night time and spoke to his family members and went to washroom with the help of MNO. Later, suddenly became dyspneic and patient was sweating. And then GRBS noted is 430 milligram per DL. We tried to shift the patient to ICU, but patient is not cooperated at that time. And he was in air hunger at that time. And the saturation of oxygen was 70% on room air. And blood pressure was 80 by 60 millimeters mercury. So we kept him on non-invasive ventilation at 10:10 p.m. but patient not tolerated NIV. He was asking for air and suddenly he became drowsy and not responding to word or pain. Immediately anesthesia team was called and they were intubating the patient at 10:20 p.m. Within few seconds of intubation, saturations were dropped. Then the patient condition further worsened and resuscitation was done, but patient could not be revived and were declared dead on 22nd March at 11:10 p.m. And possible causes of death is mostly ARDS and metabolic acidosis with hyperkalemia also there is possibility, and acute decompensated heart failure, or maybe patient came with fever with tachycardia and viral myocarditis also may be present, and cardiac arrhythmias. And because of presence of history of vomiting, there is unwitnessed aspiration of vomiters also may be caused. And the risk factors for COVID-19 disease progression in this patient, in epidemiological category 1, the patient is satisfying more than 50, patient is 56 years old, so age above 50 years is satisfying, and patient is diabetes with A1C above 7.6%. And in category 2, at the time of worsening condition, patient showed these vital signs. And category 3, D-dimer, it is less than 1000 nanogram per milliliters only. But other investigations could not be available at this time. So considering these, the patient's condition is worsening further.
Okay, thank you, Dr. Shailaja, for your nice presentation, which is very crisp. So now I understand that the patient is in the ward, not in the ICU. Okay.
Yes, sir.
Right. And then patient is hale and hearty till the night. Actually, patient was admitted in the morning, and you said all the while in the morning he was moving around to various departments for investigations like CT and all. That's what you said. You talked to me. And in the night, patient at 10 o'clock went to the restroom, and then suddenly he developed breathlessness, gasping, and within an hour, patient's saturations dropped, his BP dropped to 80 by 60, and patient's condition deteriorated rapidly. He was intubated, and within seconds of intubation, patient expired. That's what I understand by your case. Okay.
Yes.
And this doesn't qualify for the definition of a sudden death. Sudden death, usually a sudden cessation of cardiac activity with absence of spontaneous circulation. Usually, a cave coronary syndrome or a massive intracranial hemorrhage or a multifocal arrhythmias, steady D point is VTVF, or sometimes in mitral valve prolapse, certain hypertrophic cardiomyopathy and all myocarditis. In all these conditions, probably there will be a sudden death. So, is a little amendment to your title that it is not a sudden death, but a sudden and rapid deterioration of the case in a hale and hearty COVID-19 pneumonia. Now, it's over to Dr. Chilimuri to comment upon. Dr. Chilimuri.
Yeah, thank you. Can you go back to this slide, the one that you used, the last but one slide? We'll use that for the point of, just leave it here. We'll discuss the case based on this. And thank you for presenting the case. This unfortunate man obviously went to Tirupati for blessings. He didn't get those. Instead, he ended up getting a virus instead. So, they always say God will only help those who help themselves. This wasn't the right time to travel, I guess, to Tirupati unvaccinated. And unfortunately, he got an infection that looks like that he succumbed to. I just have one question. When he stepped out to the bathroom, did he take his oxygen off when he went to the bathroom? He was on supplemental oxygen. Did he take the oxygen off to go to the bathroom? Or?
No, sir. Without any oxygen support only.
Yeah.
He went, sir.
That's the classic.
Yeah. I think Dr. Kumar will discuss more about the pulmonary aspects, and I'll address the other issues. I think the differential diagnosis that you put as possible causes are all relevant, and probably fit one of them or multiple of them may have caused his death. So in the slide you put in lab categories 3, did he have an elevated troponin, or are you suggesting this as possible risk factors? Did the patient have elevated troponin when you ordered the labs?
No, sir. Troponin was not sent, sir.
Okay. So let's go through how to go about analyzing and assessing a case like this, and more importantly, what are the lessons learned for the next case that would present similarly. I think that's the real purpose of this exercise. So it is not uncommon to see patients who are admitted with severe pneumonia with COVID have problems taking that supplemental oxygen easily. I mean, they don't like nasal cannulas, they don't like this high flow oxygen, and BiPAP is even worse. So it's not uncommon that patients take off the oxygen supplements and then collapse very rapidly. So Dr. Kumar will discuss that in more detail. But let me go through the other possible differentials that you suggested, and I think there are any one of them could have caused it. Let's start with that he is a person with risk factors. So you should first assess him like any person who's diabetic admitted to the hospital. What would they possibly have? The biggest one that's staring at you is ischemic heart disease. He clearly is a male. I don't know if he's obese or not. Is he obese, or his BMI is normal?
No, sir. Normal, sir.
Okay. So that's one less factor, but he's definitely diabetic. That's a risk factor, and male sex being the second risk factor. He's over the age of 50. In many of our data sets in the United States, we use 55 and above as the risk factor, but I don't think that makes a big difference. So the first thing, did he have an acute MI? The type 2 type, in the sense that he may have had underlying coronary artery disease that we don't know of, and he became hypoxic, and then that generated, rather than the type 1 acute MI that atherosclerosis would do, in his case, oxygen death may have triggered an acute MI. We would not know because there was no EKG done at the time of collapse, nor was there any electrocardiac monitoring being done at that time. Nor do we have a troponin done in this patient at any time. So one of the take-home messages we take now from the second wave of infection is that patients who are at risk factors, particularly men, and here diabetes, hypertension, hyperlipidemia, if they have that, we do baseline troponins on them routinely. So as soon as they come in, if they have this level of hypoxia, as you saw, this level of pneumonia, he has severe pneumonia, they are susceptible to have ischemic events. So we would do a baseline troponins on them, and they kind of predict outcomes quite reliably. We've seen patients with elevated troponins end up with either they have acute MIs or they have myocarditis, and more importantly, develop all kind of cardiac arrhythmias, which he could have developed in the final moments of his life. And that also we don't know because we don't have any tracings of him at that point. So going back forward, I think a patient like this with risk factors, I would do baseline troponins on them. That's number one. Did he have a cardiac arrhythmia? I think it's possible. He is at risk to it. The risk factors again being his underlying ischemia or coronary artery disease and profound hypoxia. You mentioned whether he developed hyperkalemia. So when he came in, his electrolytes seemed to be normal, but his glucose was fairly high. It's, I think, 350 or so, and that continued to worsen. When he came in, he was not in DKA, but I'm not so sure how carefully we monitored for anion gap as he was in the hospital. By day 3, if his glucose was rising despite of your insulin supplements, I'm beginning to get concerned that he may have slipped into DKA, which it needs to be proven. Obviously, we have to do ketones and anion gaps, which we haven't done on the final day. We don't have labs on him. So DKA is, what's unusual about DKA in COVID patients is that you don't have high serum glucose levels. So you would get DKA around 350, 400. So don't expect to see 600 and 800 glucoses in these patients. So 350 is enough to get DKA, and it's something that you want to monitor. But would DKA itself kill so rapidly? Unlikely it would have killed so rapidly. But the problem with DKA in patients with COVID is that they have a high rate of pulmonary embolism. So DKA is a risk factor to develop pulmonary embolism in COVID-19 patients, probably because there's already endothelial activation, and they are dehydrated when they're in DKA. And obviously thromboembolic phenomena is fairly common in patients with COVID, and Dr. Kumar will talk about the possibility of embolism. The next possibility, so can he have DKA itself causing his collapse? It's possible if he developed a PE. The next thing that you suggested, whether he had hyperkalemia because of renal failure. When he came in, his creatinine was not high, but his BUN was somewhat rising, which tells me that he was beginning to get dehydrated, and maybe we haven't kept up with fluids, but that's difficult to assess because you assumed his cardiovascular function to be normal. I would have preferred to get an echo. This is the second take-home point that I think people at risk factors where you're contemplating on giving lots of fluids, you need to get a good LV function estimate on them, because you could flood them with fluids, and many of them, when they get this bad pneumonia, also develop acute LV dysfunction. If you do echoes in the first 3 days of severe COVID, you will see significant enlargement of the LV. You would also see collapse of the right ventricle on a regular basis. So you get both left heart failure and right heart failure in them because they are pumping against enormous pulmonary hypertension. And clearly in this patient with that level of pneumonias, I'm pretty sure his pulmonary pressures are pretty high. So there you can get a cardiovascular collapse from it by itself. So to know that, you need to have some level of a cardiovascular function estimate. Physical exam alone will not tell you whether he had any problem with that or not. In terms of hyperkalemia, we do see, so unlike other AKIs, patients with COVID AKIs tend to have a relatively higher degree of hyperkalemia. And the levels may start off as mild as 5.8, but you would see 7.1s and 8 potassiums. There is a study out where they actually compared two groups of patients, those who had AKI with COVID and another group with AKI without COVID. And they dialyzed both groups and found that even with dialysis, hyperkalemia was particularly difficult to treat in patients with COVID, and the mechanism is unclear. Possibilities is that the virus is activating the ACE system so enormously that somehow that's also affecting the potassium metabolism or excretion. It's not clear. That's possible that happens. In this patient, we don't know how long he has diabetes. There's a possibility that he could have type 4 RTA already. On top of that, if you get COVID, you're obviously going to get very high potassiums, and they develop pretty rapidly in him. And that could have caused him to develop acute an arrhythmia leading to cardiac arrest. The other possibilities is, again, in the heart, we have seen patients get pericarditis with pericardial effusions and even tamponade. He has some features of it. He came in with what looked like a fairly stable vital signs, and then within a matter of days, he rapidly deteriorated. There's a possibility that he had acute pericarditis and developed tamponade and succumbed to it. Once again, it is a very difficult diagnosis to make. So unless you're thinking about it, so you had just about 1 hour of rapid deterioration. So how many things can you address and treat in that 30 to 60 minutes? So the way, if I look at your situation at that point, it's easy for me to sit here today and I said, these are the differential diagnoses. For you, more importantly, you want to know what can I do at that point that could make a difference. So in that 1 hour of period, I think the respiratory function part, I think Dr. Kumar will comment on it, because I think having a blood gas is important. We didn't appear to have done a blood gas. He's going to comment on that. But leave that aside. What could you have done? Number one, I think in the first wave, we were instructing people, don't intubate them. If they end up on ventilators, that then they don't come off it. That's a lesson that went too far, I think. I think there are people who require ventilator support and should be ventilated. In his case, we have to ensure that that once he's deteriorating, I would intubate at that point. He clearly had bad pneumonias. There's nothing that we were doing that would make them better significantly. I think you gave him dexamethasone and ivermectin. Did you give dexamethasone? I didn't notice whether you gave it or not. But I know you gave ivermectin and the B complex. We don't think that works much. There is at least one study now in a placebo-controlled trial showing that is not effective in severe pneumonia, which is what your patient had. So let's and looking at the medications that you actually gave, one of the things I always want to check is if by any chance the medications we gave made the situation worse. For instance, when we were using hydrochloroquine, that would have worsened this QT interval and caused prolonged QT and torsade. That could have happened. The other drugs like azithromycin also prolong QT intervals. In his case, in the beginning, he had normal QVC and QT intervals as I see it, but that doesn't mean on the day of death that hasn't worsened. There's one study that just came out in which they just studied EKGs in patients with COVID and categorized into mild COVID, moderate COVID, and severe COVID, and they then did routine EKGs every day to see which way the EKG would change. And in this group, they weren't giving any medications like azithromycin or hydrochloroquine a Tamiflu, which all increase the QT interval. So these group of patients were not on any drugs that were prolonging the QT interval or any arrhythmogenic drugs. So when they compared them, they found that COVID, which is severe, tends to have a short QRS complex and a wide QTC. So as the disease gets worsened, the QT intervals prolongs, as well as the QRS complex becomes narrow and narrow. So you get a setting yourself for having a malignant arrhythmia, because the repolarization syndromes are possible once your QRS is becoming narrow. And when the QTC is becoming wider, you obviously will get ventricular arrhythmias and have a code from that, which is possible in that patient. And one of the theories that suggested is based on another basic science study where they found that when interleukin-6 levels were very high, that seemed to have affected the QTC interval. In this case, we don't know his interleukin levels. I mean, again, these levels are unreliable estimates, but where it was done in the study setting, they found that a storm of IL-6 altered the EKG findings, and therefore they became arrhythmogenic. This patient is possible that may have happened in his case, but fortunately, you didn't give him any medications which would have caused it. But the severity of his illness itself could have triggered that. So that would be the other possibility that why he collapsed. I think I will now move. I'll have Dr. Kumar. Why don't you comment on the respiratory functions, and then we'll come back and see what else we could have done differently or learn from this case going forward.
Sure, Dr. Sridhar. Shailaja, could you go back to the previous slide of differential diagnosis? Yeah. And before we go and dissect into this differential diagnosis, what all Dr. Sridhar has said, see, as a lot of medical students are here and postgraduates are there, I just want to remind you that for a shock, this patient in the end, the BP was 80/60. So the causes of shock, you all just recollect the 4 T's and 4 H's. That is hypovolemia, hypoxemia, hypothermia, hypoglycemia, hypokalemia, hyperkalemia, and H ion increase, that is acidosis. So all these H's would be possible in this case. And coming to the T's, one, tension pneumothorax, another is tamponade, as he has already said, just it is a summary kind of thing. So in the 4 T's, one is tension pneumothorax, second is tamponade, third is thrombus, thrombus of the pulmonary artery, coronary artery thrombus, and 4 is toxins. So he talked about the drugs. Probably toxins would be the surrogate word for the drugs. So what all Dr. Sridhar has said, that is summarized in these 4 H's and 4 T's. More than 4 H's, now they say 7 H's. Okay. So coming to the respiratory part of it, this case, actually, the onset of symptoms is only 4 days, if I understand. But there is a florid pneumonia. If you understand the timeline of the COVID, the pneumonia will occur on the 8th day and usually progress to ARDS on the 11th day. But here, the things happened on the 4th day. But this is not uncommon. As in the previous wave, in the last year, we have observed several cases of early onset florid pneumonias deteriorating into ARDS and dying. So, one, a misrepresented history by the patient or his authorized legal attendant, or probably the ARDS is happening early before the timeline of 8 to 11 days. That is one atypicity in this case. And second thing, had we done an ABG, by Berlin's definition, if the PaO2 by FiO2 is less than 300, then it would qualify to be called as ARDS. So in this case, the chest X-ray shows bilateral, peripheral, infiltrates, and the CT scan shows a lot of peripheral basal consolidations and ground glass opacities and interlobular and intralobular sepal thickening, consistent with the diagnosis of COVID pneumonia. And to call it as ARDS, you know, the ABG PaO2 by FiO2 should be there. And if you recollect the Berlin's definition of ARDS, the onset of insult within 7 days. But in COVID, usually it is more than 7 days, 8th to 11th day. That is the reason why now the ARDS in COVID is, they are calling it as CARDS, COVID ARDS, because it is not completely satisfying the Berlin's criteria. Coming to this present case, if we think that it is ARDS, so patient is hale and hearty since morning until 10 p.m. And all of a sudden, see, what you have said is a 95% on room air. So most probably, I don't presume that he is on oxygen. You said it is on room air. So we never did an exercise oxygen desaturation. That's not warranted to be done. Do so. Anyway, while going to the restroom, probably on exertion, his oxygen might have deteriorated, or in the history, I noted a point that there was a history of vomitings. Probably in the restroom, he has vomited, and some of the vomitus has been aspirated as a bolus, asphyxiating aspiration, probably causing sudden deterioration in his saturation, and he was brought back to the bed. And this all happened in a ward rather than an ICU. So there will be definitely less resuscitatory measures, investigational gadgets, and all. So this is what would have happened if we think of the first possibility. And here, if he had any, because he has walked to the restroom, the hypoxia might have precipitated a myocardial infarction leading to a cardiogenic pulmonary edema, brought back to the bed, and he could not be resuscitated. That's another possibility apart from ARDS. And actually, what we need in a good ICU is a POCUS, that is point of care ultrasound. Had we had a point of care ultrasound, we would have done a cursory echocardiogram where we can note a regional motion, wall motion abnormality, or a decreased LV function, or you can notice any tamponade, or if you just drop back to the chest, maybe you might be finding, B lines. And in the CT, the pleural effusions are conspicuous. It is a rarity in a COVID ARDS for pleural effusions, unless there is an overzealous fluid administration leading to fluid overload, or there is a coexisting cardiac failure leading to the pulmonary edema and pleural effusion. So that is another thing. So point of care ultrasound would be the hour of the need. Just on the spot, on the bed, we would have done a 2D echo and just look at the chest for a B lines. Of course, B lines can be seen in COVID ARDS also. So this is as far as this ARDS is concerned. And then probably once you brought back to the patient, you would have kept the patient on NIV. Obviously, when the saturations are so low as 70 and 50%, patient won't tolerate NIV because his minute volumes are also not sufficient. And second thing, the air hunger means he's having tachypnea. That means minute volumes are not sufficient. That's why he is increasing his respiratory rate. That is representing as air hunger. So definitely your NIV won't help. And intubation, and it has been taken up. And I have noted a point in the history that within seconds of intubation, his saturations worsened further. So first thing, I don't doubt, but in a hurry and in a fear of intubating a COVID patient, probably errors may creep in, whether it is a tracheal intubation or an esophageal intubation. That is the reason why once we have intubated, the saturations have dropped. How do we know? Patient will be talking or groaning because his vocal cords will be functioning if it is an esophageal intubation. And once you connect it to the ventilator, there will be low pressure alarm and a low expiratory tidal volume alarm and all these things. And there will be obviously a gurgling sound at the upper abdomen. So this is one thing. And sometimes maybe the endotracheal tube may be too far down in the right main bronchus, leading to right main tube intubation, leading to only one lung, and the other lung might have collapsed, causing further oxygen deterioration. Already it's a bad lung because of the COVID ARDS, and if the tube has gone too far into the right main bronchus, the left lung collapses, causing further oxygen deterioration. So we have to check these two things. Whenever, immediately, naturally, if you intubate, you expect a saturation to improve. But on intubation, if the saturations are failing, means this, either of these possible. This is possible. So as far as my views are concerned regarding the ARDS and the desaturations immediately after this, these are the possibilities. And once hypoxia sets in, obviously there will be myocardial infarction, cardiac failure, hypotension, and shock and death in a period of minutes. That what would have happened. And I think the rest of the things, viral myocarditis, cardiac arrhythmia, and the internal medicine aspect of it, again, I'll go back to Dr. Sridhar Chilimuri.
Yeah. I think you made good points. One of the problems with intubation, as you mentioned, apart from what medication was used to sedate the patient, do you recall what medication was used? In case you don't, one of the things that I would avoid using, which was widely used in the US, is propofol. So what happens in patients with ARDS and COVID, they really have high pulmonary hypertension. And if you give propofol, there will be a sudden bottoming out of the blood pressure so profound that it'll be very difficult to revive them, and sometimes they collapse from that itself. So we prefer using any other drug other than propofol, or use it only if you know the pulmonary hypertension is not that severe. It's a commonly used drug widely in the US for anesthesiologists to intubate. Hopefully that was not used. And I think the pneumothorax is an issue, especially after intubations. We see them. That's why we require that as soon as you intubate, we do a chest X-ray to make sure that the ET tube is in the right place. But more importantly, we do, because before you intubate, you're bagging them, and that bagging itself can cause pneumothorax, which makes everything far worse. So that's something that I would watch for after you intubate the patient. So that's another point with the intubations and all the other issues that Dr. Kumar presented. The other thing is, the big thing is pulmonary embolism. Did he have massive pulmonary embolism? Typically, when you try to get up and move, that's when you dislodge the clot. And his attempt to go to the bathroom, he already might have, for various reasons, endothelial activation, COVID itself, and the high D dimers will all suggest that he's at risk to get a massive embolism. And sure enough, when he got up and walked to the bed and then came back, he completely collapsed. Somewhere during that time, he may have developed a massive embolism, leading to a complete right heart failure. And that is impossible to retrieve him off at that point. That could be the other thing that we didn't discuss, but he is at risk. And in a few autopsies that were done, we haven't done any autopsies on COVID patients because our pathologists refused to do them. We found that PE is very common and is probably one of the common causes of sudden death or rapid deterioration in patients with COVID. If it's not acute MI, or if it's not an arrhythmia or a heart failure, I think pulmonary embolism is very high on his list of causing the sudden deterioration of his condition. I think that's something that we have to think about. So going back at that point, what could you have done differently if you were to get just another case like this? With you don't have an EKG. So I would do the EKG. I think next time you come across a patient like this, you immediately bring him back to the bed. ABC, airway, breathing, circulation, you would establish that. So you did that, you intubated him, and then obviously you would connect the ventilator and watch his oxygenation. That part is done. The second is I would do an EKG rapidly to see if there's an arrhythmia that you could treat. Third is if you don't have a point of care echocardiogram, then you have to assume or do an exam to see if there's any chance that he has tamponades. They're not common in COVID, so I'm not so much worried about them. But they do happen. We do see pericardial effusions, and the problem with them is cardiologists don't like to use steroids with acute pericarditis. But in COVID, steroids are indicated to use. But even if you were to use them, they'll take another day, 2 days before they work, and you will just have 1 hour to save this patient. So either you diagnose tamponade and drain it, or you lost that case. So that's nothing much you could do about it. The third thing is hyperkalemia. Since you don't have an electrolyte at that point, the EKG would guide you. I would do an emergent EKG and see what happened to the QTCs and QVCs. And then if you couldn't do that, I would assume that he has hyperkalemia and treat it as such. So I would give him calcium gluconate at that point. He's already on insulin. I probably will give him sodium bicarbonate also at that point. Because you're trying now salvage therapy, you don't have much time and you need to move rapidly. And hopefully, if it's hyperkalemia, that calcium gluconate will protect him and give you more time as you have to evaluate. But without it, he would die anyway. So that's what I would do next time in the 30 minutes or so that you had with the patient. And I would do a blood gas for sure. But anyway, that's more a test that I'm not so sure how much the blood gas will help you after you intubate it. So the key thing is make sure there's no pneumothorax, make sure there's no pericardial tamponade. And if there was hyperkalemia, which you can't measure at that time, I would treat it like he has it. There's more chance that he will have hyperkalemia than any other electrolyte imbalance. So I would just treat it as such. I would give him calcium and another shot of sodium bicarbonate and insulin, just hoping that if it's hyperkalemia, it will get better. But I will tell you, we've lost many patients like this. This happens fairly regularly with COVID patients. There are any number of patients with COVID who have collapsed in the bathroom, and that is a warning sign. So when a patient tells you, who's admitted to your ward or ICU, and says, I want to go to the bathroom, I think that person should never be allowed to go to the bathroom unaccompanied. I think a nurse at a minimum should be there, and that person can gauge it, and I would not disconnect any of the oxygen saturation apparatus, keep it on, and watch this person as they go and bring them back carefully. You leave them and let them go to the bathroom on their own, they'll collapse. And taking that oxygen is lethal to them. I think they cannot be without that oxygen supplements, even for a single minute. And so that's another thing that I would caution you about. In Japan, they did a study where they compared people who were treated with COVID at homes and people who were treated with COVID in hotels, because when they didn't want to admit, these were the two other places that they treated. And they found that people who were treated in hotels did much better than people who were treated in their homes. And the reason being that people who were treated at hotels had a nurse with them at all times. And people who were treated at homes did not have the nurse. And the nurse made that big difference because she would catch this person at the right time and bring him back and made sure that the oxygen was being given and things like that. So that's how it worked. So that's how I caution on it. If you were to choose a patient like that to be managed on a ward, you really have to have this nurse watching this person carefully as he goes to the bathroom and out. If he were in an ICU, that would have been better. But if it's a ward, I would use a bedside toilet rather than let them walk to the bathroom. Those are the comments I have, and I'm happy to take questions from others.
Dr. Shalamuri, this is Dr. Suresh. I think this, when you look at the whole history and the vitals and everything, this patient has almost normal vital signs, except that mild tachycardia and a sudden drop in the oxygenation. It's which after going to the bathroom come back. As you said, it's probably high likely it's a pulmonary embolism, massive pulmonary embolism. This patient D-dimer was elevated, and this patient is diabetic and also mildly dehydrated. So they're all predisposing factor to develop pulmonary embolism. Is it not better, or is it better for us to treat these patients very early in the, as soon as the patient was seen in the hospital, to treat with the anticoagulation and hydration, which might have prevented the PE? Of course, there are studies for all over, but most of these patients, when we treat, we start them with anticoagulations very early. And in this patient, especially with the D-dimer elevated, I'm not sure whether anticoagulation was given to the patient or not. That would have been probably prevented.
Yeah, I want to ask Sailaja, did we give anticoagulants, and did you actually give Dexa and what dexamethasone, and what was the dose you gave? We can't hear you, Sailaja.
Hello, sir.
Yeah. So go ahead.
Dexamethasone 0.5 mg per kg, sir.
Dexamethasone. Did you give anticoagulants at all?
No, sir. We didn't give.
Yeah, I think it's a good point. In United States, if the D-dimers are high, they will at least get an intermediate dose of anticoagulants for sure. But it's debatable whether. So I think the better way is to search for a PE in this case. I think the CAT scan not show a PE, if I recall it. I don't know if it was a kind of CAT scan that looked for PE. I don't see a PE on CAT scan. Dr. Kumar? Yeah. So I think that's fine. Whether to give anticoagulants, there's no data that it prevents death, but there's no data that it actually harms. Yeah, I think it would have been reasonable to give anticoagulants because the D-dimers are high.
And it is also a standard routine practice in the US for any patient that admitted in the hospital should be on DVT prophylaxis anyway. That's one of the problems that we are seeing often, that developing PE in hospitals.
Just pulmonary edema kind of thing, consolidations and GGUS.
Yeah.
We didn't keep pulmonary
We're not able to hear you.
Not
You're breaking, Dr. Prem Kumar.
Yeah, we can't hear you well.
Okay, they don't.
Okay, try now.
And I would say that we have to.
Dr. Premkar, you probably can close the camera and talk. Probably that will take. Looks like your Wi-Fi is not having enough bandwidth.
Dr. Prem Kumar, shut off your Wi-Fi. I mean, camera. He's gone.
Yeah.
Okay. All right. Dr. Prem Kumar is not working at all. You might want to log off and log back in, please. Dr. Chilmuri, please continue.
Oh, those are the comments I have. I'm waiting for others to add.
Dr. Suresh and Sridhar, actually, we have to introspect our protocol.
Yeah, we're not able to hear him.
Dr. Prem Kumar, please log off and log back in. In the meantime, I have a question here.
Dr. Chilamuri, it was a wonderful case discussion. I have a couple of questions. So when I trained in VGH, the theoretical part that we discussed today seems to be wonderful. However, how soon can we get a help when we call for help? In United States, in a touch of a button, we have people arrive at the bedside. But in India, where I trained, how do we teach our younger generation when to escalate the patient to an ICU? When should the patient be moved to the ICU? How do you anticipate beforehand until the things go out of hand? And the second thing is, how well are we getting the help to the bedside in a regular ward?
Yeah, I think those are the challenges of logistics. I would say even in the United States, sometimes we struggle to get a patient into ICU beds because they're not that readily available. I think it has to be a team effort right from the beginning. I think each hospital should establish some criteria. I said, if you come like this, there's a good chance that you will either end up in an ICU. I'd rather bring them from a higher level to a lower level rather than moving from a lower level to a higher level when they collapse. I think when you look at his X-ray, it looked really bad to begin with, and it looked like there's an underestimation of how severe his disease was. His X-ray looked a lot worse than how he looked. And so this is not unusual in COVID, and I think this is one thing that we need to be careful. If you have risk factors and your pneumonia is looking so severe, it's nearly 90% of his lungs, I would do those additional tests. Do the troponin, do an EKG, and do an echo, so you get a good estimate of how sick your patient is. Here, he looked okay. And unfortunately, even inexperienced clinicians underestimate this. When they look okay, they think, okay, we'll manage him here and we'll see. And then within no time, they rapidly deteriorate and collapse. This is what happened to us in April 2020. We've become a lot more cautious about that. So that phenomena of happy hypoxia, where the patient actually is hypoxic, but he looks happy, is a true phenomenon. It does happen. Patients will say, I'm doing fine. I don't want this. I don't want that. And then 12 hours later, completely collapse. So this is a problem with COVID in particular. So I think overestimation of the disease is okay. Underestimation of the severity of the disease always leads to bad outcomes. That's why I think in this case, him being diabetic and male, not knowing his underlying coronary artery disease, I would do routine EKG. In the US, we will do an echo on them because we want to know how much of fluids to give him. Because when he did his initial CAT scan, he has bilateral pleural effusions. And bilateral pleural effusions is not a feature of COVID pneumonia. So those fluids are coming from somewhere else. And one of the places you have to worry is it because he already has cardiac dysfunction? And I think the physical exam that was done demonstrated no cardiovascular disease at all. They say heart sounds were normal, everything seemed okay. Which I would question again. I think we need to go back and look at, was it really okay, number one. The second heart sound at least should have been loud when this patient clearly has pulmonary hypertension. So those sort of subtleties we can't ignore. Man, Indians are known for their physical exam skills, and we can't let them go down even in the modern day. You know, King George Hospital, the professors would be tough on us if you missed a loud second heart sound. You know, you could be you could get into serious trouble, I think. So we can't give up those physical exam skills. They're still useful, especially where you can't get things at a touch of a button. Then you have to rely on your clinical skills, which is what I was saying. In half an hour time, how you're going to manage this patient is crucial. You don't have your electrolytes, you don't have anything, then you're using a lot of clinical judgments. And I think the young physicians in India have to develop those experiences rapidly. What else can you do? You can't build massive ICUs in India overnight. So we have to deal with what we have. So that's what I would do. I would anticipate these problems like an acute MI or tamponade or a hyperkalemia and treat as such, and none of them will harm the patient. So that's how I would go about.
I have a question for
Okay.
Dr. Shailaja. Could you have done exercise oxygen desaturation? Because you seem to have oxygen saturation available. Is that routinely done? And second question related to the previous discussion is, was the ICU available? Were ICU beds available, or it was not considered?
ICU beds are available, sir, but patient not cooperated to go to ICU, sir, at that
Outside.
time.
I see.
The
What
patient
about
didn't want to go, then that's what happens. Yeah.
how about exercise oxygen desaturation? Because the initial was 95. And from what you were saying, Dr. Chilamuri, somebody like this could have, although he did not look happy, he had happy hypoxia. Exercise desaturation test could have told us that he's in trouble. No?
No, we don't do exercise exercise desaturation because it's dangerous. You know, when you take them to walk, they could collapse, and then that will be a catastrophe. So we don't. We just go and monitor them more carefully and see that in the meanwhile you're getting the accompanying test, right? If the troponin is high, you know you already have hypoxia, cardiac ischemia is happening. So you want those surrogate tests rather than walk the patient at that time. I think that would be pretty dangerous to do because that's what he did. He walked to the bathroom and collapsed and never came off it. So I wouldn't exercise it.
Right. Dr. Sridhar, am I audible now?
Yes.
What I was talking to is, as far as this treatment is concerned, we here, even though everything is protocolized, we are compelled to give, unproven treatments or discounted treatment like, doxycycline or ivermectin and all those things. Actually, for mild disease, if the simple supportive treatment is okay, and remdesivir for moderate illness and not for mechanical ventilated patients, and oxygen requiring patients and mechanical ventilation patients, dexamethasone, and Clexane, that is the anticoagulant. It is a protocol in place, but we have to introspect. Our attending doctors should write the treatment in that way, evidence-based medicine, the remdesivir, dexamethasone, and Clexane, as per the indication. That's one thing. And second thing is, it is the point of care. Okay, some disturbance is there.
Patient. Can you mute that person? Can you mute that person?
Yeah. I see.
Yeah.
In GoToMeeting, I don't know how to mute the others. In the principal's chamber, Shivaraj is there. Sir, do you know how to mute?
Yes, sir.
Can you mute all the speakers except Prem Kumar?
Please unmute yourself, sir.
Okay, now, yeah, I've unmuted. And another thing is, last year, the WIMS hospital was recognized as a state COVID hospital, where the ICU was provided with point of care portable small devices made by Abbott. They are iStat. And small cartridges were available and which could do D-dimer or drop eye and all this on the spot. But unfortunately, I don't think they're available in KGH ICU, the iStat portable gadgets. If they are available, that would be more useful for the postgraduates and senior residents who are working over there, so that they can immediately do the drop eye or even ABG can be done with a cartridge there in the same iStat Abbott's, and even a D-dimer can be done. I think I'll talk to the, actually I'm also a member of the state expert committee for COVID. I'll talk to Dr. Vinod Kumar IAS about providing all these things to KGH ICU also.
That's good. Yeah, a point of care ultrasound would be the most useful instrument for them to have. I think that will really guide you how much of fluids to give, whether there's tamponade or not. And if there is no tamponade, let's assume you did have it and you did an echo, there was no pericardial effusion, and you have this profound hypotension. At that point, the echo would show if he has a massive PE, you would see the intraventricular deviation and a right ventricular collapse. You would have seen it. And then the question is, can you give TPA at that time in a regular ward in KGH? Well, if you want to do something substantial, that's the only thing available at that time. So I would give him TPA because it would be an indication. Massive PE with hypotension is an indication to do thrombolytic therapy, and I would have given him at that point. Whether would it work in half an hour time that you have, probably may not have, but it's worth attempting at that point.
Dr. Chilmuri, after I came to United States, the one thing I learned here is how to counsel a patient. Yes, the patient is in real dire emergency, but he or she should know what is going on. While the team is working on the patient, at least one resident or somebody has to take charge to at least tell the patient, inform the patient what is going on. Can you please teach our younger people how to counsel? Because I really think it is very, very important.
Yeah, I think his reluctance to go to ICU is a little, I'm baffled by it. Is it because he thinks there's a cost to it, that he can't afford it? Is that the reason why? Or he has heard negative stories of ICU, that if you go to ICU, you won't come out, stories like that. And I would, since the son appears to be with him, we could co-opt the son also into discussing with the father and convincing him why ICU is better option. And I think that's one of the things. With COVID is there's a lot of psychological elements to it. When you get sick, you see a lot of people dying from it, so you feel you're about to die and give up quite easily. And that's one reason they think this is my fate and I'm going to die. Therefore, I'm no longer going to fight. And that's another reason why people may choose not to go to ICU. So the virus plays with your mind in one way or the other, because you're living in a pandemic, you've seen a lot of people die. So there is you need to spend some time at the bedside. And I think the risk of infection is high for the healthcare personnel. So they tend to spend very little time because of the PPE use and the difficulty to talk with PPEs. So it's not uncommon that patients get less than a minute or two at the bedside and everything is being monitored remotely. And that's unfortunate. I think you must have a decent conversation with the patient, set the expectations and what will work and what he shouldn't do and why it's important to wear the mask and what would happen if he takes it off. And I'm sure you did all of that, but I think he still didn't want to listen. I'm not sure if the son is allowed to come to the ICU, because I think there are visitor restrictions. So then you can use a phone call, and use a FaceTime call with the son and the father or whoever else he wants to take. Get as much help as you can to talk to the father and convincing him. Sometimes it may not be his wife or his son who will convince him, but his best friend who he might listen to, and get that person involved and say, can you talk to this Mr. Rao and see if he can be convinced to keep the mask on at all times and maybe go to the ICU because he needs to go there. I would do all of that.
Dr. Shailaja might tell us what actually happened. Do you know why he refused to go to the ICU? Your speaker is mute.
She's muted.
Unmute. Siva, can you unmute her, please?
Sir, patient at admission time also, sir, they were arguing that they don't want to admit in the hospital, but because of pressure, they have admitted that patient, sir. And patient is anxious from the time of admission also.
Yeah. Yeah, I mean, there are some people who anxiety is fairly common in them, so it's not uncommon to see it. There is at least one study where they found that giving mild tranquilizers, this might come as a surprise for you, that low-dose benzodiazepines was actually useful, that patients were more likely to keep the mask on and be more comfortable with the mask when they're given low-dose anxiolytics like short-acting benzodiazepines. I mean, you would be surprised that why would you give that in somebody who was in respiratory distress? But fortunately, in that study, actually, it helped for the person to keep his oxygen on, keep his BiPAP on, and can alleviate the anxiety that was going with it. Sometimes that may be the reason why everything is going wrong, because he's anxious about, the feeling of hypoxia is an extraordinarily difficult thing to experience. I got sick with COVID myself. And I had a very mild illness, but on the 6th or the 7th day, I experienced that mild hypoxia for a day. And I've never been short of breath in my life other than when you're sprinting or something. But that hypoxia, even though it lasted for a minute, was extraordinarily stressful to go through because it's very difficult to understand what it means to feel air hunger. And I'm not asking each of you to experience it to understand the difficulty for the patient, but take it from me, it's extraordinarily stressful, and a little bit of hand holding and counseling the patient to calm down, that you are with him, that the entire team is with him, and set goals in life. I mean, why is he trying to live? He's trying to live so that he wants to be with his family. Go back to what he normally does and see his son grow and get a job. So like those realistic goals, you talk about the patient and he might come around, okay, this is the purpose of my life. I'm living for these reasons. And so I will listen to the doctors and do what I'm supposed to do because I can beat this. That sort of mindset you have to create for the patient. Otherwise, they'll refuse, they're anxious, and they're just harming themselves. They're not really helping themselves.
Dr. Sridhar, would you enlighten us a little on CPR and COVID?
So in CPR, it's rarely successful. When you reach the point of CPR, if you have specific reasons that may have caused it, you could reverse it. Like if you have hyperkalemia and you treat it, that's fine. If you have tamponade and you're doing CPR and then you drain it, I think that's fine. By and large, otherwise, a patient like this with ARDS, and let's assume he also has massive PE, rarely survives. So we set our limits to 10 minutes and say, because the risk of personnel getting it and the reward for the effort is very low, so the risk is high, reward is very low. Because when you're doing CPR, secretions are flying all over the place. Even though in general, we're doing CPRs later in the course, you probably don't shed that much virus, but he's in his 4th and 5th day from what we're hearing in the history. He's still shedding virus. So if you're doing CPR at that point, I think you're risking yourself, but you're probably not getting any reward. So we set it at 10 minutes. We restrict it to 2-person CPR. It's not like 4 or 5 people going anymore. And if it works, it works. If it doesn't, that's the end of that. That's how we end it. That's our CPR protocol, and that's what's widely used in the US.
Dr. Shailaja, you might have a comment regarding doxycycline and ivermectin. Is that still a protocol? Do you routinely give them? And what's the current protocol for those?
Actually, in our hospital, they're giving routinely, sir.
I see.
I think in severe pneumonia, there's no data for its value, both drugs, doxycycline and ivermectin. In severe pneumonia, there's no data supporting that they're useful. They're widely used in Asia and South America, but no one has published data showing it's useful. The published data shows it's not useful.
So it's possible for you to take it back to your department or your professor, because I noticed, only now I understood, Dr. Prem Kumar does not directly work in KGH. Is that correct?
Yeah, he works at Chest Hospital.
So is it possible for you to take this discussion back to your department, your professor, to see whether they are following current protocols? Because I was a little surprised about ivermectin.
If you want to take something back to your professor, the ones that I certainly want is, and I've been arguing, I think 2-3 times before when I attended this conference, I was raising this issue. Everyone should have an echo. If you are sick enough to be admitted in a hospital, you need an echo and you need a troponin. You have to know how your LV, your cardiac function is. It is one of the biggest contributors of death other than hypoxia. And we are not addressing it adequately. Everyone should get an echo. That's what I would advocate if you're going to your professor and convincing him, get an echo. If he has such a bad pneumonia, I'd like to get an echo and troponin. I think the paradigm has shifted. Everybody gets an echo. That's standard of care now.
Okay.
Okay.
I have been monitoring the chat box. There are no other questions. For those that are on right now, do you have any other questions for Dr. Prem Kumar or Dr. Chilimuri, please? So for those senior people, it appears to me from the brief monitoring of the news, there is a surge in India in general, and what's happening in Vizag? Vizag also has increased cases or not yet?
Yes, sir. It's increasing.
Increasing.
Actually, Vizag also had a big surge, sir, and almost per day 170. Yesterday 159 cases, and there was a sudden spurt in a engineering college, AU Engineering College, 53 yesterday and 100 positives probably today, and definitely the cases are increasing. Even in AP also the cases are increasing. Definitely this is a second surge, and I advise all the people to wear the masks to protect themselves. Though they think that they are protected by vaccination, I don't think, it is, our vaccine is only 70% efficacious, and I don't know which person develops antibodies, which person develops T cell response, or who don't. So the only thing which can protect us even from variants is wearing a mask. I sincerely urge everyone to wear the mask and just publicize the same in the general public too. Thank you.
Yeah, I think.
I just may want to add one. In the last 2 weeks, I've seen that the doubling of the cases happened in 2 weeks this time, in the last 2 weeks, when compared to the first wave, where the doubling happened in 4 weeks. So it's probably a lot faster exponential growth that we're seeing in India. It looks like everybody is thinking that we're not going to get the second wave. I really want to warn, we need to educate public and definitely increase the awareness of this second wave. And we are seeing that Brazil is collapsing. I really want to be concerned, and everyone has to understand rather than be in a denial phase. So I think you all have to campaign for an aggressive preventive measures.
I agree. I think India is making mistakes for which we will pay dearly for it. We've developed some complacency. There's a general belief in India that COVID is a mild illness. This case illustrates that it's not always mild. I think the messaging should be very consistent. Number one, that COVID in a vast number of people is a mild illness. Two, COVID, even in mild illness, some individuals will have endothelial activation and they can develop PE and MI and really bad complications, even if they had mild illness. Third, I would say that masking clearly is effective. Fourth, the vaccines are very effective in preventing severe illness. When they say 70% in the Indian vaccine, AstraZeneca one, please bear in mind, if you look at actually severe illness, that vaccine prevents nearly 85 to 90% of that also. So the goal is not to just prevent the mild illness. The real goal of the vaccine is to prevent severe illness, because that's what this patient had. That's why this patient died. So that's the other message you want to give, that vaccinate everyone because you want to prevent severe illness. I think people will say, oh, all I had is a mild illness. What's the big deal? I don't want to vaccinate. Yeah, but you don't know when you will get the severe illness and who will get it. We know some risk factors, but beyond that, it's perfectly, this person, who would have thought he would have died, who would die? You wouldn't know. When he came in, he didn't look like it. So that's the point of COVID. It's still an unpredictable, dangerous virus. So if there is one treatment that's available that prevents severe illness, that is proven to be vaccine. So we should push that message. Masks and vaccines, that's the way we're going to end this. There's no other way. But rather than that, we're opening up, we're going to focus on economy, we're going to have cricket matches with 70,000 people in the stadium. That is foolish and unwise. And I think as a result, you're seeing what's happening in Maharashtra. They have the highest number of infections. I think if they did contact tracing, they would find at least 30,000 of those people at that cricket stadium were from the state of Maharashtra returning back and spreading the virus all over. I think we have to learn lessons from the first wave. We have to learn lessons from what's happening in Brazil. We can't make the same mistakes again. So I would urge masks and vaccines to everyone in India. As much as possible, we should push it.
Sridhar, there is one question on the chat box. Could you please review current treatment protocols? What would you do at the mild cases upon arrival, and how those treatment protocols could be applied here if the resources were there in KGH?
The first thing is mild cases, we don't need to admit them. So I think the KGH has a good criteria about who should be admitted and who should not be admitted. And that's crucial, because once you have that, then you can always monitor enough ICU and CCU beds and the regular floor beds. And I think KGH has managed bed status fairly well. As Dr. Sailaja said, she had ICU beds, which is very nice to have. Brazil can't say that, and we can't always say that in many countries in Europe either. So set criteria what you want to admit and what you don't want to admit. I think moderate to severe cases need to be admitted. The treatment protocol, number one, is dexamethasone. If the patient moderate means most likely has hypoxia, so that would be indicated. Dexamethasone should be given. I think the current dose of 6 milligrams twice a day is about the standard. There's a lot of controversy whether higher doses are useful. There's no data supporting its use. Some people use it anecdotally. So dexamethasone is still the most effective treatment available. Remdesivir, yes, Dr. Prem Kumar pointed out, we use it widely. The data is still not very convincing that it decreases mortality, but it decreases length of stay of the hospital. That data still holds true. That's still an optimal goal to have. I wish it decreases mortality, but it hasn't. Those are the two things that we widely use. All other treatments are up and down. I think if you're going to use cytokine inhibitors like tocilizumab or anakinra, the data is mixed. Sometimes it seemed to work, and sometimes some studies it didn't work. I think case selection is the important thing. I think we increasingly begin to become aware that not everybody has a cytokine storm, that I think 20% of people really have a robust cytokine storm and have complications from it. At least there's one study where they did detailed analysis of every cytokine available, not a large amount of patients, but some, and showed that not everybody is getting cytokine storm. I think we're throwing this everybody, oh, you have cytokine giving tocilizumab and whatnot, and it's not working. On the other hand, there will be some who will have a dramatic improvement in 24 to 48 hours after they get tocilizumab. So I think case selection is still unclear who to give it to. For the plasma, again, same type of results. If the plasma had high amount of antibody titers, it worked. In some people, again, in others, it didn't work. I think timing is very important. If you give it early, it might work. If you gave it late, like 6 days after that level of severe pneumonia, it won't work. If at all plasma is going to work for this particular patient we presented today, it would have worked on day 1, if at all. It wouldn't have worked later on. The anticoagulants are, if the D dimers are high, we would give it. There is at least 2 studies, placebo-controlled trials, showing that it's beneficial. Although I will argue that there are a couple of other studies which didn't show benefit. But the Mount Sinai study was done fairly well, and it showed a decrease in mortality from at least thromboembolic disease like PE and stroke. So I think it's worth giving it. There is no higher rate of complications from anticoagulants like bleeding. So therefore, I would always give it to them. And then the rest is based on what you're seeing. If you see hyperkalemia, you have to treat it appropriately. We do now advocate for dialysis, although we don't do dialyze every day, but you could dialyze based on need. So you could do intermittent kidney replacement therapy, and that's shown to be effective. And I think that's the current standards of care right now. Not a lot of improvement. If you, from 1 year to now, I wouldn't say we made huge progress. I think the biggest progress are still that we know masks are effective and vaccines will prevent severe illness. I think those are the biggest advances 1 year after COVID. When you will be laughing at me, I'm saying masks are the biggest advance. Yes, we now have solid data that they prevent infections, and you must spare them. And we know vaccine data is very convincing that it prevents severe illness, and we should push those 2. Those are the things.
I must tell you, I never laughed at you, but I didn't take you seriously when you were telling me in the beginning about the first surge. And look what has happened. But Dr. Martanda Sastry put in a message there just now. I want to read that these variants, the new variants, the severe variants, could be a complete game changer just when people are exhausted and are not following the restrictions and are fed up. This could be a serious problem. We are opening up way too soon. I just read his comments. I think it is so true. As much as we are all involved in treating the public health aspect of it, telling everybody, even on the street. So I was talking to Sudhakar yesterday about the medical students doing a project on the beach road. You know, the beach road in Vizag is very popular. Why doesn't every medical student stop people? You can actually even do studies. Sir, when the vaccine becomes available, will you be taking it? No, I don't take the vaccine. Why not? Even you can generate that kind of information. So a white-coated young doctor stopping a gentleman on Vizag Beach Road might have an impact, because I think there is a serious public health education failure. Seriously.
Hold on. Dr. Chilumuri, I don't know how your New Yorkers are behaving. This morning I'm post-call, stood in the parking lot for a minute to see all my staff coming into through the like employee like in a door, and none of them were wearing masks. So we ourselves are not behaving well. So we are talking about Beach Road.
I don't know what we means. I'm talking about the physicians. The physicians, if they don't have enough supplies. They don't have echocardiography. They don't have blood gases everywhere. We could still use our white coat to teach, is the point I'm making. But I don't think we do enough of that.
Yeah. I think the message has to be consistent, and I don't tell people this is a mild illness, don't worry about it. Don't say that. You can always say this is a mild illness for you, but you need to be careful. I would prefer you not get infected. That's my first preference. And to do that, wear a mask. Number two, when you get infected, monitor it carefully. The second week of the illness, it will get worse in some individuals, and we need to recognize them quickly and seek medical attention. That's the second thing. Third thing, mild illness is not really mild in everyone. It's mild in 95% of people, but 5% will end up with some complications. So just talk like that. Don't minimize the disease. That's what political leaders will do. That's what the Brazilian president did and harmed his country. And so did Donald Trump did that. And I think, oh, it'll just go away. It hasn't gone away. It is here, and we have to deal with it. And sooner we realize it, the better we are.
To add that, Sridhar, the mild illness, even the mild illness, we have seen focal myocarditis and the reports of other problems in the long term. So the mild illness is not really a mild illness. And Dr. Kairam and I have invited Martan Sastry, who is my senior, who is attending here his genetics. He was my actually mentor during the medical school as well as here. So I invited him to join this, and he's going to be helpful in providing genetic aspects of these diseases in the future. Hopefully he'll be a regular attendee.
There is one more question on the chat. Is there any role for Fabi flu in mild to moderate disease? I must admit I haven't recognized the spelling of this. Fabi flu?
No evidence that it's useful.
Fabi flu is favipiravir, and there is no evidence that it works, and there's a lot of pill burden, and a few studies say that it hastens a little viral clearance, but I don't believe it, and very little support for using it.
You both might have already addressed this question. Can we start anticoagulant to all COVID-19 cases? Is there any criteria to start anticoagulant in the beginning?
Giving it to all has shown not to be beneficial, and therefore we would recommend only giving it to either people who have proven to have an embolism or people who have high D-dimers, not routinely. If the D-dimer is normal, they've given it to them. In one study, it showed no benefit at all. So I wouldn't give that. I would only give if they have high D-dimers or if there's evidence of embolism.
So I'm very unhappy today that there is not a universal acceptance of 800 white-coated young doctors going on the beach road in Visakhapatnam. I'll go there myself.
Okay. I think we have to.
Dr. Prem Kumar, Dr. Chilamuri, Dr. Anne, thank you very much for your time. And in the absence of Dr. Sudhakar, I'm very glad that we did not break, because he is so proud that this is the 36th unbroken COVID webinar in India. So thank you all.